Good afternoon, everyone, and welcome to our third session in our birth injury webinar series. Today's webinar is looking at shoulder dystocia in birth injury claims. During the webinar, you can please pop any questions, or if you want to put it in the chat or Q&A on the top of your computer. Pop any questions in there for us, and we will try and get to as many as we can at the end of the webinar. Please note that our recordings and the slides will be made available after the webinar. For those of you joining us for the first time, welcome. Just a little bit about INNEG. We work with over 13,000 experts nationwide, and our superpower is helping solicitors access the right experts across every major discipline. I am very pleased to welcome our speaker today, Ms. Nikki Khan. Ms. Khan has been a midwife for 35 years and has been an experienced expert witness preparing medico-legal reports in INNEG since 2017?
2015, 16, it's around 2016, yeah, I did it.
Yes, and your specialist obviously interest is in shoulder dystocia and birth injury claims. Thanks very much for joining us, Nikki, and take it away.
Hi, everyone. I have, as Vanessa said, been qualified for 35 years, and I've seen things change throughout those years. And protocols being put in place. So I'm going through a bit of history when I go through these slides about shoulder dystocia, as well as identifying pitfalls throughout the notes that can be picked up by yourselves or via your midwifery experts. So this is just a summary of myself. I've been, like I said, a midwife for 35 plus years. I do claimant and defendant instructions, and I've been qualified in doing midwifery expert witness work since 2016, actually it is. First of all, shoulder dystocia. From a midwife's perspective, once you have been involved in a shoulder dystocia, you never forget it. It is one of the most distressing things as a health professional, and also obviously for the mother involved. It is something that is normally it is something that is unpredictable, but there are indicators that you can pick up on it. Now, shoulder dystocia is when the baby's head has been born, but the shoulders have become stuck. Now, when the baby's head comes out like this, the normal situation after this is restitution occurs, which is when the body turns to allow the shoulders to come out. Now, at this point, when the head's stuck, you can see that the nerves in the neck are completely stretched. And it is these nerves that, when they're affected, cause Erb's palsy or brachial plexus injuries. Now, as I said, shoulder dystocia is usually unexpected. However, there are possibilities and ways of predicting this throughout the analysis of the medical records. Now, often people don't go back as far as the booking, but it's quite important because there's red flags in antenatal care which can identify those at risk. Previous shoulder dystocia is a obvious one, that if someone's got a previous shoulder dystocia, they are at greater risk of having it in second pregnancies. The other one is type 1 diabetes or gestational diabetes, which can lead to fetal macrosomia, which is babies that are above the 90th centile. 95th centile even. One of the issues that is on the increase, unfortunately, is late onset gestational diabetes, and I'll talk about this a bit later. It's something that they do a 28-week GTT, glucose tolerance test, and when the third trimester starts to approach and the fetus starts to grow quite markedly, they fail to do a second glucose tolerance test, and it is in that late onset gestational diabetes is often missed, and it's becoming quite relevant in a lot of cases that I've dealt with over the years. Another red flag is if a mum's got a booking BMI of over 30. And when I first qualified, we used to do weights at every appointment, every antenatal appointment. It's not the case now. you do a booking weight, but there is, if mum is noticing that she is beginning to get excessive weight gain through her pregnancy, that is another indicator of a potential risk of shoulder dystocia, as is advanced maternal age. And ironically, we think about babies that are above 4.5 kilos as being most at risk of difficulty delivering the shoulders, whereas 50% of all instances of shoulder dystocia occur in babies weighing less than 4 kilos, which is quite surprising. It's the aspect of the traveler and the vehicle. So mum is the vehicle and the baby is the traveler. And it's often the case that the size of mum's pelvis is the issue, though, rather than the size of the baby. Now, red flags in antenatal care continuing when reviewing the maternity notes is if mum's having an induced labour, that's an indicator that there could be a potential risk of shoulder dystocia. Also, prolonged first or second stage. Now, if when you do a vaginal examination, you're checking the descent of the baby's head, and there's a way of assessing if the baby is descending down into the pelvis. Now, if the baby is staying stuck at the spines, as they say, and not descending, that is an indicator that there could be a potential risk of getting stuck when the head is being delivered, after the head is being delivered. This is one of the scariest sights. I know it looks a bit graphic. You can see that this is mum's perineum and this is the baby's head, and it's called turtlenecking. It's the first sign that things are going wrong. You have the fetal head will emerge and it will retract, it will go in and out as it's trying to restitute the body so the shoulders can be released, and it starts to struggle. As soon as a midwife sees this or sees difficulty with delivering the chin, the urgency is relevant. So we have the turtleneck sign, then the failure of restitution, which is when the baby's head doesn't rotate to allow the shoulders to be released, and then difficulty delivering the face or chin. Like I said, these are immediately should be called for help and assistance. There's two mnemonics that people use. One is called alarmer and one is called helper nowadays. And it's a way of midwives remembering the situation and what the maneuvers are. With regards to helper, the first thing is you ring the emergency buzzer. It's not a case of calling a second midwife in, you call the emergency buzzer immediately. And then they say evaluate for episiotomy. Now, this is very another mode that's questionable. Episiotomy doesn't help increase the pelvis or help the actual maneuver of the baby. It helps if you're going to do the maneuvers such as the wood screw or removing the posterior arm or the reverse wood screw maneuvers, but it shouldn't be done immediately until you have done the McRoberts and the suprapubic pressure has been applied. The reason for this is that if an episiotomy is done too early, it's one of the reasons why women end up with fourth degree tears, because it's only needed when you are requiring maneuvers, not for the McRoberts and not for the suprapubic pressure to be applied. So it does give this a way of women, mums, midwives remembering the routine. So McRoberts is the first port of call, then suprapubic, then you do your maneuvers to enable the body to be released. There's various documentation that's relevant at the time. The RCOG guidelines are being updated this year, and the intrapartum NICE guidelines were updated in November 2025. Now, with regards to the guidelines themselves, it's so relevant that the trust guidelines are incorporated into the analysis when you're doing expert reports and reviewing expert reports. And one of the main issues that I've found recently, I've just had a joint expert meeting with a case, and unfortunately it got to the stage of joint expert meetings and the guidelines that my counterpart was using were post-dating the incident. Now, the issue is that if a baby's delivered in 2002, or NICE guidelines weren't even enforced really then. So it's something that is quite important when you're actually reviewing expert reports and analysing the records themselves. I'm probably telling you how to suck eggs here, so I'm sorry about this. Skills and training post 2002, it became relevant that there was a necessity for annual obstetric emergency drill training to be applied to maintain mandatory competencies after birth injuries started to become quite paramount with shoulder dystocia. And their trusts can change this. They adapted it. So the trust guidelines then changed depending on where their hospital was, and they even incorporated scenarios such as postpartum hemorrhage or shoulder dystocia on a monthly or even 3 to 4 times a year. So it's relevant to what the trusts are doing at the time. Now, the reason this is important is that you need to know if the midwife who's been attending the birth had the relevant training. So if it's early 2000, and because the reason I'm putting this in place is because birth injuries can occur 21 years or no limitation if the baby's obviously lost capacity. So these birth injuries can go back a long time. And it's quite important to realize that in the early 2000s, PROMPT, which was practical obstetric multi-professional training, was developed. And this was launched at Bristol Hospital in the early 2000s, which proved that there was a need to have some sort of training in place to prevent these outcomes. Then in 2008, there was the implementation of mandatory multi-professional training, but it still wasn't completely nationwide. And it was only really in 2019 and 2020 that it was solidified, although 2009 to 2010, it did become that most trusts were doing annual training. So it is quite relevant in the way that you need to know what the trust was incorporating into teaching so that the midwives involved in the care were aware of the maneuvers. Now, like I said, timings and documentation is so important. So as soon as the turtling is evident, the midwife would look up, check the time, and pull the emergency buzzer. It's very similar to an emergency situation in A&E when you have somebody come into resus, someone is told they are the scribe, and they will write down the time the drugs are given, the time that the woman is intubated, things like this. With regards to shoulder dystocia, the scribe is so important. So the first thing you do is you stop maternal pushing, and then you start the maneuvers. Now, the maneuvers include McRoberts and suprapubic pressure, and each maneuver should be made for 30 seconds to a minute and then moved on. The aim is that there should be a delivery of the fetus delivery of the shoulders within 5 minutes of the delivery of the head. Now, it's important that you document this duration, the second stage of the labor, and the time of the delivery of the head from the body, because there's this 5-minute threshold, which is if a head to body delivery time is less than 5 minutes, you'll have a lower rate of HIE. After 5 minutes, the risk of neonatal depression and brain injury and even death is increased significantly. You've got normally within 10 to 12 minutes, there's severe permanent neurological damage. So time is ticking as soon as this turtling is evident. The interesting thing to note is that following delivery of the fetal head, the umbilical cord pH drops by approximately 0.04 units per minute. Now, it doesn't seem like it's that much, but if a baby is born already hypoxic, or if a baby is born with already a borderline pH and it's continuing to drop over a period of 10 minutes, this baby is going to be born very poorly. Over the duration of my being qualified as a midwife, the primary focus has evolved from simply pulling harder, which was always the way initially, to these specific techniques, which are increase maternal pelvic diameter and angles, and decrease fetal shoulder diameter. Now, suprapubic versus fundal pressure. Fundal pressure should never be used with shoulder dystocia, as it causes further impaction and brachial plexus injuries and can even cause uterine rupture. Now, it still carries on, unfortunately, and you'll hear this from a witness statement when the woman will say, you'll say to a woman, where was the midwife pushing? And pushing on the pubic bone compared to a woman saying right underneath my ribcage, my breasts, is completely different. So this is why witness statements are so important, because the witness statement might well say that she was pushing at the top, whereas the documented records will say suprapubic pressure was applied. So it's very much for the court to decide, but the relevance of what the mum recalls is so important. McRoberts maneuver as well needs to be done correctly. The knees need to be brought up and pushed towards mum's head, which will increase the pelvic diameter down here. This maneuver, just holding the legs up or in lithotomy, doesn't work. So you need to make sure that you've got the correct maneuvers being performed as well. So McRoberts maneuver first came into place in 1983, but it became universal in 1990s and used combined with suprapubic pressure. So it became very paramount as being the one thing that would reduce would release the shoulders to be delivered. As I said, it involves grabbing the mum's legs, hyperflexing them tightly against the abdomen, and then abducting the legs. It's extremely uncomfortable for the mother, but it straightens the sacrum and rotates the symphysis pubis so it frees the anterior shoulder, and it does work. So many times it works if it is done quickly and efficiently. And it's the first sign of maneuver. Following this is the Woods corkscrew maneuver, which is if the McRoberts and the suprapubic pressure isn't working, you can do suprapubic pressure along with the Woods corkscrew maneuver, which is, I'll show you a picture which might indicate it better. It's when the finger is put inside to help release the shoulder on the posterior surface of the posterior shoulder. So you can see at this stage, an episiotomy would probably be required because it would allow space for the maneuvers to take place. So there is a role for an episiotomy, but it isn't until you actually need the space for the maneuvers. Now, the Gaskin maneuver is when literally you go on all fours. It's very rarely done because a lot of women have epidurals, and to move someone onto all fours is quite difficult that late in labor. But it can be very effective, and it resolves in over 80% of attempts. It actually is quite successful. So it is another maneuver that has taken place. Now, this maneuver is one that is very rarely done, but saying that, it was performed in 2026, where it saved both mother and child after all other maneuvers failed. It involves pushing the baby's head back into the pelvis and then performing an emergency cesarean section. Now, the problem with something like this, even though it can have success rate of 92%, it can cause damage to if too much damage is done pushing the baby's head in, it can cause ping pong fractures or damage to the skull itself. So it is a really, really difficult procedure and one that isn't recommended. Now, it's still used today, like I said, but as very much a last resort. This is something I put in only because when I worked in Saudi Arabia, I saw this being used, and it was a very last resort. They actually cut the symphysis pubis, and it can cause catastrophic injury to the mum in the way of long-term issues with walking, pelvic pain, and urinary continence. It is very rarely used. In fact, I've never seen it used in developed countries, but it is used in developing countries if they don't have access to the operating theatres. So Now, as a result of the damage to the nerves, the most common brachial injuries are when the nerves C5 and C6 are damaged with the shoulder dystocia delivery, and it's often caused by too much pulling or too much traction. If maneuvers are done correctly, Erb's palsy and brachial plexus nerve injuries should not occur. It's caused by excessive stretching of the neck shoulder, where the shoulder gets stuck. And even though in most babies recover within 3 to 12 months, often they suffer permanent damage, which can be life-changing for them. Now, like I said, it's generally positive, the prognosis. Approximately 70 to 80% of children recover fully within the first 3 to 6 months. However, if there's no significant improvement by 3 to 6 months, the nerve grafts or muscle reconstruction can even be necessary. Now, it can cause severe ongoing problems for the child as they experience weakness in the effector side, which can include later in life reduced grip, reduced function, can affect writing, lifting objects, and in turn can impact all activities of daily living and their future career. So these are cases which are potentially avoidable if the right maneuvers take place. But it is something that unfortunately still occurs. Now, the legal principles in the management of shoulder dystocia is what is avoidable and what is unavoidable. If shoulder dystocia can be prevented, as in if it can be picked up as being something that can be treated by having an earlier induction at 38 to 39 weeks if mum has got macrosomia or previous shoulder dystocia or booked elective section, this is something that needs to be addressed in the antenatal period. If it's something that we can address as in when the delivery is evident and the turtling appears and there is a failure to call the emergency buzzer and instead they just pull the buzzer and a second midwife comes in, that is negligent because they should call the emergency buzzer as soon as the incident happens with the turtling, because timing is such an issue at this case. Like I said, failure to use standard protocols such as the McRoberts maneuver rather than simply pulling determines negligence. Now, why things go wrong? It's really difficult because everyone instigates immediately that shoulder dystocia is once shoulder dystocia occurs, it's negligent. It's not. Sometimes it happens and you don't know it's going to happen. But that is why all midwives should be aware of the timing factor of the risk of getting that baby's head out within 5 minutes, calling for help, the correct maneuvers to take place. So not acting from the diagnosis of shoulder dystocia quickly enough is one of the main things. Failing to detect the problem and referring on for urgent obstetric input is another. So as soon as you see the turtling, when you call the emergency bell, obstetrician will attend at the same time. The incorrect management of dystocia, such as excessive force or using inappropriate maneuvers such as fundal pressure, and incorrect McRoberts maneuver. Failure to monitor the baby in utero prior to labor and to act accordingly. What this means is if the baby has grown in the second trimester, in the last trimester, and the late onset gestational diabetes has been missed, this is something that should have been addressed. And if the mother has now gone 42 weeks, the reason they ask for earlier induction for big babies is because from 37 weeks, the main thing the babies do are grow. So inducing a mum at 38 weeks potentially reduces the baby growing any bigger. So it does not necessarily prevent shoulder dystocia, but it reduces the risk of the baby being larger at the time of delivery. Now, I've put mismanagement of episiotomy as part of the manoeuvres. The reason this is because if it's done too early, before the manoeuvres are required, it can then extend into a nasty 4th-degree tear. So this is then causing an injury to the mother that could have potentially been avoided. And as I said, witness statements are vital from everyone in the room, as it's a really scary situation. And often when things are documented, they can differ to what the parents will call, but it's really important that this is taken on board. Now, I've done two case laws. This one is the one to do with brachial plexus injury, and it took place in 2020. There's numerous ones that are available, but this one occurred because they have emphasized that poor record keeping, poor document keeping during the emergency deliveries made the defendants unable to defend this claim, because there was no documentation saying what time the maneuvers were done and when the maneuvers done and whether they were done correctly. Improper traction was used rather than the recommended techniques, which lent to the permanent Erb's palsy. So that was that one. And then the one we all know is Montgomery, which came into place in 2015. And this was when a diabetic mum of small stature wasn't told that she had the increased risk of a 10% increased risk of shoulder dystocia if she went ahead with a vaginal delivery. Even though the appropriate maneuvers were performed, there was a 12-minute delay, which caused severe oxygen deprivation to the baby. Now, following this, the ruling overturned Bolam test and stated that it is in a context of informed consent, replacing it with a patient-focused duty to disclose risks, so that she is informed of the material risks of what could happen if she went ahead with a delivery when she had a large baby on board. So it's the fact now that we need to, if a baby is larger in the last trimester, we need to inform the mum that this is something that is a risk that could occur. Now, the HSIB findings in 2021 were quite interesting in that they stated that shoulder dystocia affects nearly 4,000 babies to 4,500 babies in England each year. And if properly handled, doesn't lead to long-term injury. As a nation, we are getting a major problem with obesity now. And this in turn is making babies bigger. And in turn is increasing the chances of shoulder dystocia. Now, even though big babies aren't necessarily always the ones that are at risk of shoulder dystocia, it is something that we need to be quite aware of. It is said, HSIB said that 31 of the 326 maternal investigation reports involved babies who were injured in shoulder dystocia. And out of that, 2 of those 31 babies were stillborn as a result of the shoulder dystocia. And the other 28 babies were diagnosed with HIE. Now, the main themes that they identified was that there was an inconsistent identification and management of large babies during pregnancy. It's very difficult because scans aren't always correct. And a mum can be told that she is having as a baby that's over more than 90%, on the 90th centile, which means that it's bigger than 90% of babies at that gestational age. However, she can then go ahead and deliver a baby that is less than 90th centile. So it's not necessarily as accurate as we would like them to be, but they are what we have to rely on. Now, women in labour with suspected large babies need to be offered the option to continue with the pregnancy, to augment in such as induce the labour, or to have a caesarean section. They should be given the option. And I think this is one of the things that is lacking through cases that I've had to deal with as an expert, that they are not given the option of what they would do with knowing that they had a baby who is on the larger side in utero. Screening for gestational diabetes. This is what I was saying about, that there is, if a baby, mum has a risk of gestational diabetes or has a risk of developing it, they will do a GTT at 28 weeks. If it is normal, no further gestational tolerance tests are undertaken. However, late onset gestational diabetes can occur in the third trimester, going up to delivery, and the fundal height can increase quite markedly in size. The old-fashioned way was to measure the fundal height, and if it was more than 2 centimeters, you then, because fundal height should equal term gestation, you would then refer on for growth scans. They now have various charts that are put in place that should identify, as the scan, as the growth is plotted, if the baby is increasing in height, increasing in size in utero. Even though this is documented in the growth charts, from cases that I've undertaken as an expert, no gestational tolerance test is undertaken. And often they will have developed this, and the baby will be born, and the baby will be treated like a diabetic baby. So it is something that is unfortunately missed in various aspects. They are plotting the growth, but they're not acting on the growth being increasing in size. Sharing information with mothers, so important. Talking to the mother, just explaining what's going on. This goes down to the fact, giving her the right to choose, empowering her what she should choose. If it's a large baby on board, it's not advisable to have a home birth, and the mother should be explained to the risks of going ahead with a home birth. If she has an increased risk of a shoulder dystocia, she needs to be told that she needs to be somewhere where there can be emergency input straight away, and recognition of shoulder dystocia. Now, in these outcomes, 31 of the cases, it took between 2 to 25 minutes to deliver the body after delivery of the baby's head. And if you think that the blood gases are dropping at 0.4 pH every minute that ticks away, those babies are undoubtedly going to be born brain damaged if they're post 5 minutes or 10 minutes predominantly. Most of the babies' umbilical cord blood gases were normal. These babies are born in poor condition and need a resuscitation, which suggests that compression of the umbilical cord vessels have blocked the transfer of oxygen. Some babies showed a profound and prolonged hypoxia after only a short delay in delivery. This suggests that the oxygen deprivation began beforehand. So there was a contributory factor. So these babies were already compromised before they got to the stage of the shoulder dystocia. And 6 of the 31 babies sustained additional birth injuries, such as brachial, plexus, Erb's palsy injuries, 3 with fractured humerus. Whilst I worked in Saudi Arabia, we had the doctors, two babies had fractured clavicles when they were born. It doesn't have to be an aggressive way of delivering. If the maneuvers are done okay, you are increasing the angle, you are trying to get that baby out. It's a scary situation, but the maneuvers are put in place to be followed. And if one practitioner isn't successful, often the obstetrician will then take over. But it is the timing factor. 30 seconds to a minute with each maneuver. Go through them. If it doesn't work, then do them again. So it's just keeping an eye on the clock the whole time. And here I put the fetal cord blood gases. Now, the reason I put these in place is to do with the 0.4 dropping. If you think that this is a normal fetal blood gas or umbilical cord blood gases, if it's dropping 0.4 gases and the baby's already compromised at birth, this baby's going to be born very damaged. Now, that's the end of my slides, but the main thing I think I wanted to put forward is that shoulder dystocia is unpredictable. It's also can be avoided if it's picked up in the antenatal period, and it can be treated if it's as long as the maneuvers are followed, then there's a good outcome, potentially a good outcome. After a baby's born with HIE, this isn't my territory, but then you have to also ensure that the resuscitation takes place. So when the emergency bus is pulled, the neonatal team should be called as well at the same time, and they will be there. But it can often be a case of a cascade of events if the resuscitation is compromised as well. And therefore, as long as the baby has cooling within the first 6 hours and suffers some HIE, then in that case, hopefully there will be a better outcome. But it's a terrifying situation. And that's the end of my slides. So
Oh, thank you, Nikki. That was an extremely useful and practical session. I'm sure everybody will join me in thanking you for that. Before we move on to the Q&A, I just want to remind everybody of our next webinar, which will be on Wednesday, the 3rd of June. It's in relation to breast cancer clinical negligence, where we'll be focusing on delayed treatment decisions and outcome. We will send full details in a follow-up email, so please can you look out for that. I'll have a look now on the Q&A, but just before I do that, Nikki, I was going to ask you how you balance your work life between obviously your clinical side and your medico-legal side.
Yeah, it's difficult because I worked as a midwife until 2024, and then for health reasons I couldn't practice as a midwife anymore, but I do expert midwifery work at the moment. I think it's very interesting in the way that you have to be very aware of, like I was saying, the guidelines at the time of the incident occurred.
Yes.
So it's almost like you have to go back in time sometimes. So I find that it's a massive benefit being qualified this long, but it also can be a bit of a handicap because you tend to forget sometimes about what the situation was back in the 90s. But
Yes.
if that's the situation and you've got a birth injury of 1997 shoulder dystocia, often, luckily, I've got most of my textbooks going back to that stage, and that's what you have to rely on if it's pre-guidelines.
Yes. Thanks very much. If I can ask you what you would do, sort of what your take is on if there's discrepancy between the notes and the witness's recollection or the mum's recollection, how do you approach that as an expert?
I think it's difficult because I think often it's down to the court to decide. But if a mother who doesn't really understand maneuvers is telling you in a witness statement that she felt pressure and underneath her breasts, and the
Yes.
husband's saying the same, you've got two people in the room all saying the same thing,
Yes.
it counteracts what was written in the records if the baby's been born with a severe shoulder dystocia, severe brain injury as well. So it's something that we shouldn't ignore. And I think it's very important to have the slant from the midwives that were in attendance at the time of the incident as well. But often
Yes.
it's really difficult if it's an old case to actually get hold of these midwives. So because they might not be around anymore, and it's difficult to get their recollection.
Yes, as you alluded to, these cases can go back to the 1990s and
Yeah, and it's hard because you think like but I will honestly say I've had two shoulder dystocias,
yes.
and I will never forget them. You never forget them. So as a midwife, you will always remember the maneuvers, or you remember it's like it's clear as day because it's one of the most terrifying things to be involved in.
To be involved in. Um, when you're dealing with shoulder dystocia cases, what are the first documents you look at, and what are you looking for? What are you trying to establish from them?
When you look at it, they've got like you're looking where they've documented the maneuvers. So they
Yeah.
normally is a pro forma that's written out and kept and documented that the timings have been issued. So you're looking at whether they've done them in the right order.
Okay.
The factor, you wouldn't go right in and do the maneuvers. You wouldn't go ahead and do the internal maneuvers if you hadn't done the external maneuvers. So
Okay.
you would do first port of call, you would call for help, McRoberts and suprapubic pressure. The episiotomy is something that's a lot of people say, a lot of people don't. I think
Yes.
you tend to not forget about the mum, but the mum becomes secondary to the baby. But it
Okay.
is something that if it's done too early, that you need to address. So, yeah.
Okay, thanks very much. I think that's all we've got for the moment. If anything comes through, I'm sure we can be in touch with you. Just to let everybody know that Ms. Khan's CV, the presentation, and the slides will be made available shortly after the session. But for now, thank you very much for joining us, and enjoy the rest of your afternoon.
Okay, thank you. Bye.
Thank you.